challenging to be the last speaker before lunch. Everyone is hungry, and after so many obstacles. So after so many obstacles, we'll try to present a short case. We'll stop in the middle after each part, and we'll try to see what will be your approach to deal with those things. So it's one of the things that happens on a daily cases, and maybe we'll summarize everything that we learned this morning. So Dr. Host from our department will present the case.
Thank you very much, Chaim. I would like to recover עיניים.
לא, זה בסדר, את אחריי, זה בסדר, תודה שנוח. תקרבי לפה.
I would like to present a 78-year-old female that presented to our department with lateral anti-RMI. She had a clinical history of hypertension, hyperlipidemia. She had in the past a TIA, and she was a current smoker. Her current medication were Ramipil, simvastatin, and aspirin. And creatinine clearance for 60. Her coronary angiography revealed the proximal LAD occlusion, and we did a PCI, performed primary PCI with the implantation of a drug-eluting stent. During the PCI, ticagrelor 90 milligrams twice a day was added after a loading dose of 180 milligrams. And her echocardiography, which doesn't work here, imagine it moving. Her echocardiography demonstrated severely reduced LV function with mild to moderate MR and moderately dilated LA. And that's it. Okay. So the patient was admitted to our ICCU. 2 days after admission, the patient developed atrial fibrillation with rapid ventricular response and with compromised hemodynamics. The first question is quite clinical, if should we cardiovert the patient or not?
Dr. Zahger, would you try to?
So, she's in the ICU, and has a rapid ventricular response. She's compromised. I would cardiovert for sure, yes.
Okay.
Would you do a TEE first?
It's a good question, but if she's compromised hemodynamics, I wouldn't do a TE. I would just first stabilize her and then do a TE, because TE usually give you asthma, so
We didn't see the echo. Short duration. Yeah, we didn't see also the echo. It's quite severely reduced ventricular dysfunction.
No anti-thrombus.
No anti-thrombus. It's a late comer with ejection fraction around 20 and recent onset of the, as Professor Zahger mentioned, atrial fibrillation.
I always worry about calling something recent onset because we've learned so much that a lot of these things don't talk.
She's continuous performance of revision.
Hold on, Chaim. She had a dilated left atrium on her echocardiogram, isn't that right? So she at least has a substrate to have had AFib in the past. And I prefer to call it newly discovered atrial fibrillation rather than new onset. And I don't know if that changes your plan.
Yeah.
No, you don't know if she had it a week ago, and it was asymptomatic.
So the feeling here is first that she should have, and second issue is that maybe not to do a TE. So maybe Dr. Hoss will show us what we did.
Before I show what we did, I will just mention that the patient also had a TIA a few years ago, so it's also something that tells us that maybe she had the atrial fibrillation before. So, of course, because she was hemodynamic compromised, we gave her a loading dose of amiodarone, and we did an electrical cardioversion, and it was successful, and she regained sinus rhythm. The following days, when she was admitted, she had a few episodes of atrial fibrillation, and she was currently on aspirin and ticagrelor. What combination of antiplatelet or anticoagulation treatment should we give? Like I mentioned here, just a few of the options, because of course the options are almost endless. But
We're very fortunate. We have so many options.
No, we have
I can
more.
give you more.
We should definitely start with antagonal. This is rather easy because we are facing triple therapy this way or the other. So antagonal principle is very hostile adequately showed us. Then we want for this time dual antihypertensive therapy. So this should be aspirin and clopidogrel. And then we need an anticoagulant. And as this lady is an easy choice because even with a cell, with a health basic criteria, she's qualified for NOACs. So I think NOACs would be a very good choice, and I would start one at this point.
Do you have a recommendation for a specific one?
For this particular patient,
78, right?
she's
78 was cut in place of 60.
78.
How is the renal function?
60.
60, we gave you all the data.
I think one thing the Beer-Sheva will be a good choice. We need to go for the lower dose. So one thing the Beer-Sheva or 2.5 pixel or actually I don't think we have a clear preference here, but we need to stay to the lower dose, whatever we choose.
So what you would go
But we
for?
have the only thing I can say that most data that we have with triple therapy and with Beer-Sheva. So if we want to stick to the data, then the only study which includes the therapy is realized, so we're going to maintain the data, so basically the only one that has real data.
I'd like to make a suggestion. Sometimes we have to tailor therapy. Maybe what I suggest is not I would say orthodox, but we have to tailor therapy to a specific patient. Right now, I feel that the major problem is our coronary event. And I'm asking, the audience, if we want to make sure, we want to ensure the patency of the treated artery, maybe we have to put the emphasis on the new anticoagulant and somehow compromise on the anticoagulant. In other words, why not a month, let's say 4 weeks or 3 months of ticagrelor, for example, with just with some anticoagulant, not enough. And then long term, after 3 months, switch, because I think that the probable period would be the next 4 weeks for staphylococcus.
You're saying therapy for anti-coagulant for a month.
Yes.
I wouldn't do it. No,
But because of
the risk of hemorrhage.
What?
Absolutely not. Not my area. I have no preference.
I'll tell you why I wouldn't do it, Simcha. Your suggestion might be the best one, but there are no data to support it. And in this field, whatever you do can end up very bad, with very strong or very bleeding. So I prefer to do things that there's some support and some guideline support to justify what I do. What you're saying will be subjected to clinical randomized trials, no doubt, and maybe 2 years from now we'll say this is the best choice.
I don't agree with you. Now I'm safeguarding and medical legally, you're on safe ground.
So basically what you recommend is aspirin, switching from ticagrelor to Plavix, and giving one of the NOACs, preferably the Biletron 110. So if I summarize everything, let's continue with the story.
Okay. So,
Switch is not triggered.
Yeah, you have to lower with 600.
Switching is not. Okay.
okay.
So
Okay.
let's continue because it's a long case and we want to have lunch and not dinner.
A day later, the patient complained of weakness. Blood pressure was 90/60. Hemoglobin level dropped from 11.5 to 10. And a new echocardiography demonstrated new mild pericardial effusion. The main differential diagnosis was pre-rupture or early pericarditis. So what combination of antiplatelet or anticoagulation treatment should we give now?
In other words, it's a latecomer. We know that it's a big infarct. Patient is not so stable, and we have to do something now or not.
What day is it?
Day 4.
Day 4,
Day 4.
in a later item.
First, I'm very happy. Exactly, I'm very happy she's having more care than mine. I would definitely stop all anti-coagulation at this point. It doesn't matter much whether I stop the agents or not because they're there anyway. I need to take worry about this pericardial effusion, follow it, rupture, no rupture, but stop it at and see what happens.
We didn't. We decided to continue treatment with aspirin, Plavix, instead of Decagalor and Clexane, as we gave it before, and monitor closely with daily echo studies. I can tell you that when I presented this presentation to a few doctors in the department, I never got the same response twice. Each doctor tells me it's different, but it's Hadassah, so you know. During the following days, the patient was clinically stable. Her hemoglobin was between 10 and 11. On recurrent echocardiography, the pericardial fluid maintained stable. And on day 12, she was ready for discharge. What combination of antiplatelet and anticoagulation treatment should we discharge her on?
So assuming the echo now is okay and she is stable?
Stable, the same picture of echocardiography with a minimum of...
So I would go with aspirin, Plavix, and the bigger one.
Does she still have fluid?
Minimal fluid, yeah.
Very mild.
My bias would be to wait a bit more with anticoagulants. I don't know what happens with the pericardium there. The absolute risk of stroke in the next few days is not huge. I don't know what's wrong with the pericardium. I would hesitate to start anticoagulants at this point. I would maybe start, I don't know, 2 3 weeks.
Definitely, I wouldn't stop the anticoagulant and 7 hours away home. That definitely would be.
You have to understand that on the other hand, she's prone to have heavy thrombosis, as Professor Tivoli mentioned, large arterial infarct, so we are playing both sides.
She doesn't have it.
Not yet. But she's on anti-thrombotic therapy. You never know what will happen if you stop it. So actually, we might have prevented an apical thrombus by giving her anticoagulation. So it's kind of both ways.
And the fusion is stable and active treatment.
Yeah. So
But without anticoagulants.
without.
She's on Clexane.
No, they stop.
Very low dose Clexane. Very low dose Clexane. And the question is, now, before she's supposed to go home, what should you give her?
It's 12 days.
12 days. It's an elderly patient with anterior margin, 12 days until she's stabilized. Now, what do you want to give her before she goes home?
Do an anticoagulation therapy and plan for anticoagulants in maybe 2 weeks.
Any other options?
Yeah, I would give NOC plus aspirin of NOC plus propionidine. 2 rather than 3.
No, but
Doctors, they will tell you that it's against the guidelines, which you stop dual
This
treatment.
patient is not included in the guidelines.
no, but you have to bear in mind it's a proxial AD and it's a STEMI, so I would be very careful with the aspirin and Plavix. I would get aspirin and Plavix for sure.
The next day she will
I would also remind you the new guidelines from 2015 of the ASC with on non-STEMI, of course, not STEMI, that if there's a high risk of bleeding, which in this case we can, we can give dual or triple for the first month, so maybe it's another option, but I don't take slides, I'm just... Yeah.
Okay.
Okay.
So let's show what we did.
So the patient was discharged with the following treatment. She received aspirin, clopidogrel, dabigatran 110 twice a day. And
That was right.
Keep going.
Yeah. And don't worry, not for long. And yep, and beta blockers, ACE inhibitors, Lotan, atorvastatin, nomeprazole, all the. The patient was seen in the clinic after 30 days. She complained of weakness. Her ECG revealed atrial fibrillation with an average rate of 90 beats per minute. We decided to readmit her for cardioversion and antiarrhythmic treatment. She was admitted. She had a successful cardioversion. And on which medication should we discharge her now? The month after the...
No, just to add amiodarone or something.
We added amiodarone, which had some influence. But
Why didn't you continue amiodarone?
It was a clinical decision when she was discharged. We assumed that it was a new onset atrial fibrillation. She was discharged on a sign of freedom. Okay, I will talk to my head of the department. I will come up to that.
I tell you, if you want to know the real answer, we didn't give her in order to be able to have this case. This whole case study was done yesterday. There is no such a patient. If you wouldn't be given, you wouldn't have the continuation of the story.
Okay.
So, next one, and this is the last one, I think. Despite antiarrhythmic treatment with amiodarone, the patient continued to complain about recurrent episodes of palpitation and weakness. Ambulatory monitoring revealed recurrent episodes of atrial fibrillation with rapid ventricular response. We decided to refer the patient for atrial fibrillation ablation.
No, that's the last one.
People are getting hungry, Chaim.
How would you prepare her and what would you do later?
Shut up.
This is not the focus, but maybe ABJ pacemaker, age 79, or how long after the event did you refer her to atrial fibrillation?
About 5-6 months.
It's a legitimate decision, although at the age of 79, one may suggest that you can have alternative approaches, but assuming that you went to atrial ablation, you take your all the medication, stop the bigger one for 1 dose or maximum 2 doses, do the ablation and resume it after several hours.
Let's say the ablation after 1 month. She's got the DF of 20 still?
Well,
She's got an ejection fraction of 20?
oh, about, yes.
So what about CRTD if you know the
I can keep talking forever, you know.
This is the next meeting.
Okay. Yeah?
Open time.
Okay, any questions? Anybody? Okay, אז אנחנו